Hey guys, this is Miss Hill here, and we are continuing individual module 5.2, PowerPoint 2, and this is lecture 2. We stopped last time right at alterations during the intrapartum period, so we're going to pick up there and move forward. So we're talking about intrapartum care and some of the things that can happen during that time frame that moves away from a natural type birth. So alterations that can occur. We think about things like a cervix that isn't ripe enough to go through labor. So some of the interventions that we can do is some cervical ripening for those patients, where we can use medications to progress their labor, progress the ripening of their cervix to make it a little more favorable to move through the labor process. So we look at medications like Cytotec, which is a tiny little pill that is placed up into the vaginal canal close to the cervix. It dissolves there and causes contractions and ripening of the cervix. Cervidil is a long string like medication. It's soaked with a medication type, but it comes in a really long string, and that string is inserted into the vagina up next to the cervix, and it does the same thing that Cytotec does for cervical ripening. The difference in the two medications is that Cervidil can actually be removed. But once you insert Cytotec, the little pill that dissolves, you can't remove that one. So Cervidil tends to be a little bit more of a safer option, because if the woman starts to have too many contractions or become contractions start to become tachysystole, we can actually remove the Cervidil, but we cannot do that with the Cytotec. We would have to intervene in another manner, such as administering a tocolytic if contractions became too strong. Balloon catheters are another way that we can ripen the cervix, and basically a balloon catheter is very similar to a Foley catheter that has a balloon, and what you do is you just stick it into the cervix and blow it up to cause the cervix to start to open up and ripen. Labor induction is also something that we use when labor is not progressing or happening like we want it to. We use Pitocin, which is an IV fluid, or we can also artificially rupture membranes to cause this process, this labor process, to go much more quickly, to strengthen that the intensity and the duration of and the frequency of contractions. A forceps assisted birth is also an alteration whenever we're thinking about vaginal deliveries. Forceps are a type of tool that are used by the physician who is doing the vaginal delivery. They are long ring-like structures that are placed over the baby's head. So they're inserted into the mother and placed over the baby's head, and they allow the physician to, or the care provider, to put some type of traction on the fetal head to help assist the baby through the birth canal. So we would use these for a mom who's not pushing effectively, or a baby that's having some trouble coming through the birth canal. A vacuum extraction is used for the same purpose, but it's a little safer than forceps. And forceps would be used in a more severe case, and vacuum extraction is just a little suction cup that's placed on the baby's head while it's still inside of mom. And as the mother pushes as a contraction happens and the mom is pushing with that contraction, the physician can pump the suction up to cause this little suction cup to stick to the baby's head, and he can utilize some traction along with the pushing effort and the contraction to help ease the baby down through the vaginal canal. Um, An episiotomy is another way that we can help open up the vaginal canal and expand the introitus if the passageway is not cooperating like we want it to. And that is done with just a pair of sterile scissors by the care provider. It's typically done as during the second stage when mom is pushing. And if the mom does not have an epidural or is not medicated in some way, then we would use some lidocaine and numb up the area before it is snipped and paired after delivery. And then another alteration during the intrapartum period when we're thinking about vaginal deliveries are those mothers who have to go for a cesarean section. So something is not quite right with the labor process or the delivery process, and now we have to move in a different direction. We're not going to be able to deliver vaginally, so we choose to do a C-section, and that would be considered an alteration. Some dangerous signs related to the intrapartum period for mom and baby are as follows. Abnormal vital signs from a maternal standpoint, changes in her level of consciousness, inappropriate contractions, so things that are not things that are not expanding the cervix, dilating the cervix, or effacing the cervix like it should be. A full bladder can cause problems with fetal descent. A pathologic retraction ring is a constriction that will occur between the upper and the lower uterine segments during labor, and basically it just restricts the passageway in the uterus so that the baby can't move through. The other name for that is a Bandel's ring. And an abnormal abdominal contour is a danger sign that a labor nurse would be able to assess. If you end up with assessing an abdominal contour that is not symmetrical in some manner, you may be looking at a mom who is getting ready to have a uterine rupture. So that's a really key assessment point from a nursing standpoint. And then when we think about fetal danger signs, the way that we assess the fetus is through the fetal heart rate. So abnormal fetal heart rates, we may see meconium stained fluid, which tells us that the baby has had some kind of hypoxic event. When babies become extremely hyperactive, that can also be a danger sign. And fetal acidosis. So if we're doing some kind of, if we're checking oxygenation status in the fetus and we are noting that there's headed towards an acidotic state, that's also a danger sign. So let's now move into C-sections, and we're going to talk about nursing care during cesarean section deliveries. A cesarean section is a surgical procedure that allows the mom to birth her baby through an abdominal and a uterine incision. In somewhere between 2010 and 2012, around 33% of births in the United States were due to cesarean sections. However, around 2014, that number decreased to about 32%, and it may be even lower now. We try very hard to promote natural birthing, the natural birthing process, for individuals who it's going to be safe for. And one thing that we have noticed is the earlier we try to birth babies, so the earlier we try to induce moms, the worse the outcomes seem to be for the fetus and the mom, because their bodies just aren't ready to go through that process. So now there's a collaborative across the nation where we don't do any type of induction prior to 39 weeks. And the only reason we would induce a birth prior to 39 weeks would be there's some issue with the fetus that requires us to try to go ahead and deliver it early, or there's some type of problem with the mom's health that requires us to deliver her early. Otherwise, for a normal, healthy mom with the baby who's doing just fine, we're not going to schedule inductions prior to 39 weeks. And that is partly why we've seen a decrease in cesarean sections. However, rates definitely differ dramatically throughout the world and tend to be more common in urban areas, and that could also be due to some of the poverty and socioeconomic issues in urban areas as compared with rural areas. So you think about drug use, maternal health problems, the inability to get prenatal care, all those things can affect the difference between having a vaginal birth and a cesarean birth. The increased rate in the United States is probably because of the incidence of repeat cesarean births. So once you've had one, typically people will opt to have a second one if they get pregnant again. And many people, once they've had one cesarean section, they choose not to have vaginal birth after that. Women also sometimes will request to have a cesarean section to avoid the pain of labor and delivery. They want to schedule their birth time because they have things planned. It may be around the holidays, their due date may be on Christmas. So sometimes they request to have a C-section for those reasons. And also, there's a reduction in maternal hemorrhage risk as well. Depends on what doctor you get, whether or not they will accommodate that request. Most of the ones I've known won't accommodate a cesarean birth just because your due date's on Christmas. An increase in neonatal respiratory problems, having the moms and the babies have longer stays in the hospital, and increased complications in subsequent pregnancies are also issues that tie in with cesarean births. We'll talk about some of those a little bit later. And we're talking also about a seriously invasive surgery whenever we think about a cesarean birth. So all of the common post-operative complications that a patient might see after surgery, a mother can also see those after a cesarean birth. So reactions to anesthesia, infections, blood clots, bleeding, all of those are possibilities that the nurse needs to be watching out for. So why would we have a C-section? If the mom has had 2 or more C-sections in the past, she is required to have a C-section. She cannot have a vaginal birth. People who've had a classic incision, and we're going to look at what that looks like. That means a vertical incision in the uterus. Those individuals are not able to have a vaginal birth. They have to have a C-section. People with cephalopelvic disproportion, so they're not going to be successful if they try to vaginally deliver. Placenta previas and abruptions, individuals with non-reassuring fetal heart rates, preeclampsia and eclampsia, people with dysfunctional labor where things are not progressing as they should or contractions are not strong enough to dilate the cervix. Babies who have an arrest of descent in utero, so they, for whatever reason, stop descending. The cervix stops dilating. In babies that are presenting in a manner that is other than cephalic, so they're positioned wrong, their presentation is breech or transverse. Moms with an active genital herpes outbreak, umbilical cord prolapse, and then the individuals who have elective C-sections are typically those who have had a C-section before. So many of these reasons of why to have a C-section have to do with complications, which means it would be an alteration from the vaginal deliveries that we've been talking about or actual labor itself. There are some certain medical conditions that also warrant cesarean birth. Individuals that have cardiac conditions or severe respiratory disease may be more beneficial for them to deliver by a cesarean section. Individuals who have medical conditions from a central nervous system standpoint that can increase their intracranial pressure. We would want those individuals pushing during the second stage of labor because holding your breath and pushing also increases intracranial pressure. So if that individual has a process going on that already causes that increase, we don't want to make that worse. Individuals who have some type of obstruction in the passageway, also mothers who are infected with HIV. However, this one is somewhat questionable because mothers with HIV can definitely deliver vaginally. There's just a certain protocol that has to be followed very closely in terms of medications if an HIV mother delivers vaginally, but it definitely is possible and is done quite often. People who have a severe mental illness that causes them to be in some type of altered state of consciousness, those individuals may not be alert enough or aware enough to be able to participate in the labor and delivery process. So a cesarean birth may be the best option for those individuals. And then again, some other conditions associated with this type of surgery could be breech presentations, again, previous cesarean births, major congenital anomalies in the fetus, and then severe Rh isoimmunization, so the negative mom who has been cross-contaminated with the baby. The C-section can be either scheduled or it can be an emergent process. So we're looking at either something that is scheduled weeks out or something that happens quickly and on the fly. And for the emergent C-sections, those can have some lasting psychological effects on the mom and the significant other. So from a nursing standpoint, it's very important to make sure you're keeping people prepared and allowing them to have access to as much information as you possibly can, educating them, making them feel comfortable, because in an emergent situation, things move extremely fast and a lot of people come in. And sometimes the significant other cannot go back into the OR. And if he or she thinks they are going to have the opportunity to do that, and they've been told, hey, I'll come get you whenever you can come back, and then something happens in the OR and no one goes to get him because it's not okay for him to come back anymore, it's important for the nurse to take a moment and leave the operating room to go tell that significant other, hey, we have some for whatever reason, we're not able to bring you back right now, but as soon as the baby's born, we will come and get you. So letting them know they're not going to be able to come back is very important, because that's extremely stressful to think that you've taken their loved one to the operating room and that you're coming back to get them, but then you never show back up. So always keep that significant other in mind. There are risks involved and complications that can occur for both the mom and the baby, because we're talking about a surgical procedure. And if the moms have had 2 or more C-sections, they will always have a C-section with their later pregnancies. But if they've only had 1 C-section, it is possible for them to have a vaginal birth with the second pregnancy and with later pregnancies. Some individuals are poor candidates for C-sections, and just a few, this lists only a few of those, but people who are anemic, because you're going to lose more blood during surgery, they might not be the best candidate for a C-section. Chronic illnesses like cardiovascular disease or individuals with diabetes. We know people with diabetes don't heal as well. People with cardiovascular disease, it might not be good for them to have a C-section, because also sometimes they are a little more slow to heal as well. Moms with advancing age, just because they're older, they're more prone to infection. It takes them a longer time for their body to heal up. People with certain medication regimens, so individuals who might be on medications to thin their blood, those people would be a poor candidate for a C-section unless they had stopped taking their medication as directed by the doctor prior to that. So knowing the history about your patient is very important. And then sometimes people who have psychological things that are very severe, maybe they've had a bad experience with a surgery before and they've got some post-traumatic stress syndrome, that might not be the best candidate for a C-section. And if it is, that person's going to need some extra medication above and beyond what you would normally give. So when we look at things from a pre-op standpoint for cesarean sections, we have to consider the preferences of the parents, and those can be, there can be an enormous amount of preferences that people would like or do not like. So allowing them the opportunity to participate in what type of anesthesia they get, if possible, is important. It helps them feel empowered. The father or the significant other being present during those procedures and in the recovery room, video recording or taking pictures while the C-section happens, delaying the eye drops so that the mom can actually have some eye contact with the baby prior to putting those in. Physical contact while they're in the OR. So can we do skin to skin in the OR in the recovery room? And then breastfeeding in the recovery room within the first hour after birth. All of those things are interventions that you want to talk to the parents about and ask them what their preferences are, because you can adjust your nursing care to meet these preferences in most situations. There are a lot of information and education that has to be done. So whenever we're thinking about that type of information, we need to prepare them for what procedures to expect. If the mom is going to be having a spinal anesthetic placed, then how is that going to go? What position is she going to have to sit in? Is she going to have to take any extra medications? What's it going to feel like? All of those things are education points that you'd want to go over. Letting them know where the birthing room is going to be, where the viewing room is, if there is one in your facility, the different types of anesthesia or pain medication that is available for them, some different sensations that she might experience during the C-section, especially if she's going to get a spinal and be awake. It's important to let her know she's going to feel pressure at certain points, and it's okay to communicate with her also during the surgery as well. Um, what's the role of the significant other? So if your individual is going to be able to come back into the OR, teaching them how to put on the appropriate gear so that he can enter that sterile environment, where they're going to sit, the knowledge that you can't touch anything because things are sterile. And then how the interaction with the newborn is going to happen after it's born. Will we be able to do skin-to-skin contact there? Will we have to take the baby to the nursery and wait until mom is in recovery? And it all depends on the facility too, and the physicians. What is the immediate recovery phase going to look like? Warn her about that also, that she won't be going directly back to a room, but to a recovery area. And then talk about the postpartum phase as well. If the cesarean birth is scheduled and it's not an emergency, the nurse has plenty of time to do all this teaching. So usually it's not a concern when we're talking about scheduled C-sections. However, that's not the case whenever it's an emergency section. So we have to get in as much teaching as we can in those situations and remain calm so that the parents, the patient, and the significant other are not frightened. For patients having repeat C-sections, they have a general idea of what to expect, but people who have had negative experiences in the past need to be able to voice those negative experiences to you so that you can know what their experience was and try your best to allow them a positive experience the next time around. People who have had positive experiences in the past, on the other hand, need to be reassured that you'll do your best to make it a positive experience this time. And then all families, no matter if they're having a C-section or a vaginal birth or if they're in the hospital for something else, they always need the opportunity to discuss any fears or anxieties that they may have. And the nurse can sometimes intervene to help alleviate those fears or educate to help alleviate those anxieties. In preparation for an emergency C-section, the nurse has to make sure that she is using her most effective communication skills to support the parents. You have to make sure you're being direct, that you're being specific, but you also have to make sure that your communication skills are above par, because things, again, are moving quickly. There are lots of people in and out and a lot of things going on at one time. So you have to be sure that what you're telling them, you're effective in the way you're communicating it. You have to explain what's going to happen, why what's happening is being done, and letting her know the different types of sensations she might experience once she's in surgery. And then supporting the partner, because this can be very frightening for the partner as well. So promote participation if possible. And if that individual is not allowed to be present during the C-section or in the OR, then letting them know why they cannot be there is important. So again, making sure that everybody is psychologically prepared, doing your typical pre-op nursing care education, such as turn, cough, and deep breathe exercises, educating on ambulation, diet, pain control, making sure the mother is prepared for the actual surgery. So we may have to use the clippers and shave their belly. We may have to insert a Foley, making sure we have good IV access, a large bore catheter in a big vein, making sure jewelry is removed, that they are hydrated, that their skin is prepped. We give everybody who is going back for a C-section some type of anticholinergic and some type of anti-secretory medication as well. Informed consent is a big thing to make sure that you have checked off of your pre-op checklist. And whether is it going to be just a C-section, or are we talking about a C-section and a tubal ligation? Making sure you have the appropriate consent for actually what's being done. Making sure that the lab results have been drawn and are back, and that your physician is aware of what they are. Some places get an EKG for the C-section and some places don't. If you have an emergency that is going on, chances are you're not going to have an EKG on the chart, but an ultrasound could be very helpful and important. Making sure that you've administered the meds, so your pre-op antibiotics, any type of fluid bolus that your patient needs, the anticholinergic and the anti-secretory meds. So Bicitra and Robenal is what we typically give. Bicitra is a liquid. We usually give that to moms in a 30 ml amount, and they drink that prior to going back to the OR. And Robenal is an IM injection, and those both take care of the anti-secretory and anticholinergic. Both of those are supposed to dry up secretions and decrease the acidity of stomach fluids and stomach contents, gastric contents, so as to decrease the probability that the mom may throw up and aspirate during surgery. Making sure all jewelry, contacts, eyeglasses, any type of dentures are secured and not on the patient. Making sure that they have the correct attire, that the mom has a hat on and the significant other has their gear to put on prior to coming back. Making sure your nursery staff knows what's going on and when the patient is in the OR. And then allowing that significant other the opportunity to be educated about what his role is when he gets back. The physician will decide what type of skin incision to make on the patient based upon a lot of different information, but there are two types. We can do a transverse incision, and that is where they do the incision in a horizontal manner, sort of right above the symphysis pubis. Usually it can be hidden even when the woman wears the bikini, so that's a good one, especially if you're thinking about self-esteem of the mom after surgery, scarring, that kind of thing. So it's almost invisible after it heals. It does not allow extension of the incision if needed, however, so you have to be sure that big enough for the baby to fit through and that you're not going to have problems. A vertical incision is very quicker, and it's preferred whenever a rapid birth is needed. So in an emergency situation, sometimes you may see the vertical incision, but that's typically the main reason that a vertical incision would be used. So those were skin incisions. So now we got to talk about uterine incisions. Usually what we see is a lower transverse uterine incision, which means the incision is made on the lower uterine segment in a transverse manner, and that is the most common one. There are also uterine incisions that are done in a vertical manner, and that one is preferred if you're having twins or triplets, multiple gestation pregnancies. If the baby is in an abnormal presentation, so possibly a baby that's in a transverse position. Um, Women who have a placenta previa over that spot, we might have to use a different type of incision there. Non-reassuring fetal status, so meaning we're trying to do this quick, fast, and in a hurry, and that's the one that is the quickest. Babies that are preterm, or babies that are extremely large, so macrosomiac babies. A classic incision was the method of choice for many years, but it's not used very often today. So a classic incision is the one that is up and down. We're going to see a picture of that next. Okay, so here you have your low transverse uterine incision, and the advantages of this one is that it's unlikely to rupture during a subsequent pregnancy. So this is a good one if the mom wants to have a vaginal birth the next time around. There's less blood loss with this one. It's easier to repair, and less scar tissue and adhesions upon repair. However, the disadvantage is that there's a limited ability to extend this incision laterally to make it bigger. So once you cut it, you got to be sure that it's big enough to get the baby out, because you can't make it any bigger once it's done. A low vertical incision is another one that can be used. And the advantage is that it can be extended upward to make a larger incision if you need more room. But the disadvantages are that it is more likely to rupture during a subsequent birth, and a tear in this particular incision could extend down into the cervix. The last one that you see here is a classic incision. So this is the one that we rarely use any longer. It's in a horrible spot if you're worried about scarring and people being able to see that. But the advantage is that it's only really used if we have a placenta previa where the implantation is in a spot where you cannot use the other two incisions. It is used if the patient has a lot of adhesions or scarring from previous surgeries. This may be the only option. Or if the baby is in a transverse lie, or it's a very large fetus and the shoulders are stuck in the mom's pelvis. This might be the incision, uterine incision, that has to be used. On the flip side, this one is most likely to rupture during subsequent pregnancies and births. And this one will always eliminate a vaginal birth after cesarean as an option if the mother gets pregnant a second time. So here would kind of look like, and remember, our skin incision and our uterine incision can't, just keep that in mind. But this patient has had a classical incision. She's had a vertical skin incision and a classical uterine incision. This allows for fast delivery of the baby, but it leaves a wide scar. This patient will always have a repeat, has a very high risk for uterine rupture in the future, which is why I allow her to attempt to labor and deliver that way, vaginally. This is a low transverse incision, so this patient has had a horizontal skin incision and a low transverse uterine incision. This takes longer to perform, but the good thing is that there's less blood loss and the patient can have a VBAC in the future if she doesn't have any type of cephalopelvic disproportion. This incision is good from an integumentary standpoint. If the mom is worried about her skin or what things might look like after she heals up, because typically this one can be hidden with even when the mom wears a bikini. As the baby is born after a C-section, there's much more mucus in their airway, so deeper suction tends to be needed, and a very close attention has to be paid to the newborn's airway. Whenever a baby is born with a C-section, they do not get that squeeze like they get coming, so they their lungs because it hasn't been squeezed out. So they tend to sneeze a little more. They might, their lungs may sound junky when you listen, more so than a vaginal delivery. So making sure that you're suctioning what they have. They may cough. So from a nursing standpoint, making sure you're keeping a close eye on their airway and their breathing is very important. From a circulation standpoint, making sure that you dry them as quickly as possible and keep them warm because we're in an OR. It's very cold in the OR. So doing that quickly and getting the baby skin to skin with mom helps with circulation and temperature. If the baby is stable, we can do some skin to skin and possible breastfeeding in the OR while the doctors are repairing her abdomen. However, if the baby is not stable and we have some low APGAR scores and we're needing resuscitation, we would not be able to offer that. If the baby is a little sedated because of medications that the mom has received intraoperatively or preoperatively, making sure Narcan is available to give to the newborn per protocol is appropriate so that we can ensure that our ABCs stay intact. Your post-op nursing care for C-section patients are the same assessment and identification procedures that we use for vaginal birth. We're looking for a firm fundus. We're making sure the bladder is empty. We're checking lochia. We're doing maternal vital signs every 5, 15, 30 minutes until the mom is stable. So vital signs are a little different because we're doing those a little more frequently during the recovery period. We are doing everything we can to make efforts to assist the parents in bonding with the baby. We are doing everything we can to prevent hemorrhage, not just from a perineal standpoint. So we're not only looking at lochia and palpating the fundus, but we are also evaluating the surgical dressing. If the surgical dressing is becoming saturated, you know, from a nursing standpoint, you never remove the dressing. You mark it, you time and date it, and if you have to, you put another one on top of it. But of course, if you have somebody bleeding that much in the recovery period, you would certainly be letting your physician know. Managing their pain is very important. These people will be in more pain than a vaginal delivery. Now they have incisional and surgical pain on top of after pain from a uterine standpoint. So they've got a kind of double whammy. So making sure that you're managing that is important. Assessing their level of anesthesia. If they've had a spinal, then we're assessing their anesthesia level in terms of sensation in their lower extremities. If they have had a general anesthesia, then we are assessing their level of anesthesia in terms of level of consciousness. Making sure you're measuring urine output, looking at the color, the odor, consistency, and amount of that urine. If this patient has some bloody urine, then we got to use a lot of caution with that and notify the doctor because we're doing surgery really close down to the bladder. If we're having a C-section, there is potential to nick the bladder and cause some problems in the GU system. If the patient is putting out less than 30 milliliters an hour, that's also cautionary for the nurse. We want to hydrate them to prevent renal failure. So oftentimes they're going to be getting a bolus and they're pumped full of fluids prior to surgery and sometimes intraoperatively, and particularly if they have had a spinal, they're getting tons and tons of fluid. Turn, cough, and deep breathing your patient every 2 hours to prevent pneumonia, and helping them get up and ambulate as soon as possible helps them heal so much faster. It prevents DVTs. It allows their gastrointestinal system to start working again. Start speeding up the peristalsis there so that we don't suffer from constipation. It also allows them to get gas moving. Whenever you do a C-section on someone, you open their belly up, a lot of gas gets trapped in there once things are closed back, and that has to go somewhere. So sometimes the pain for these individuals doesn't come just from afterbirth pains or from incisional pain, but sometimes it comes from gas pain. And if they are lying in bed and they're not up and ambulating around, it's very difficult to get rid of that gas. So ambulation is super important for our C-section patients. When we discharge these people, they have to know the signs and symptoms of infection, not just from a perineal standpoint and from a lochia standpoint, but they also have to know signs and symptoms of infection from an incisional standpoint. We want them to keep that incision dry. We want them to keep it clean, so washing with a mild soap and water and making sure things are nice and dry is very important. Making sure they're monitoring their temperature when they get home, that if they start to feel bad or they start to get their incision starts to drain pus or it gets red and inflamed, very painful, all those are things they need to report back. They need to know what normal lochia is, what type of pain medicine they're going to be released with. Depending on the physician will depend on what they go home with. In my career, many of the C-section patients are going home with just 800 milligrams of Motrin to take every 6 hours or so. And I've worked with physicians who will send them home with Percocet. But as we all know, oxycodone and OxyContin are becoming more and more abused, so the prescriptions for those are less and less for individuals. And you can get pretty good effective pain control with an 800 milligram of Motrin, unless you are very tolerant to medication, then you may have to have something stronger. They need to know what to do if they get constipated or they start having bladder problems and they can't pee. They need to know those are issues that they need to report back for, but they also need to know that it's okay to take some Colace or some milk of magnesia if they get constipated. And making sure that they go home with the appropriate emergency contacts as well. It is important for them to know who to call once they get home. So let's talk a little bit about vaginal births after cesareans. Studies support VBAC as a really viable and a safe alternative for second-time mothers if they've had lower transverse uterine incisions, because they're least likely to rupture. All of these women, however, to be eligible, are offered a trial of labor after cesarean, and that's called a TOLAC. And if they do okay during that trial of labor, then we can proceed with a vaginal birth. But again, they have to meet eligibility requirements to be able to have a VBAC. So they have to not have a classical incision. They have to not have any type of cephalopelvic disproportion. The baby has to be cephalic presentation. All of those things that we consider with a normal vaginal delivery also has to be considered here with a VBAC and a TOLAC. So the American College of Obstetrics and Gynecologists have some guidelines that are related to TOLAC candidates, and those include no contraindications for a vaginal birth, They have to have 1 or 2 previous cesarean sections, low transverse uterine incision, clinically adequate pelvis, no other uterine scars, and never have had a uterine rupture prior. There's got to be a surgeon that's available during their active labor. So that means someone there and available immediately during active labor in case there is a uterine rupture. And the anesthesiologist also has to be available because if there is a uterine rupture, that person would have to go to sleep. Absolute risks of VBACs are small, but they still have to be considered. And nursing care will vary according to your institutional policies. Okay, moving on into pain management for labor and delivery. So what causes labor pain? Well, several different things, but ischemia of the uterine cells during contractions are a major cause of labor pain. There's also a lot of soft tissue stretching that happens in the cervix and the vaginal canal. Even the lower uterine segment begins to stretch out as the baby starts to descend. Pressure from the presenting part down into the pelvis. And some women want all of the pain relief they can get. Some want to cope with the pain of labor, and your role is just to educate the mom on her options and be supportive for whatever she decides to choose. So the stages of pain actually change a little in regards to the stages of labor. So in the first stage of labor, the pain is more internal. It's more organ pain, internal visceral pain. It's felt sometimes also in the back and in the legs. And the reason for these types of pain has to do with dilation and effacement of the cervix, and then distension of that lower uterine segment as the baby descends into the birth canal. Contractions also causing uterine ischemia is what causes that internal visceral pain as well. In the second stage, pain is much more localized and somatic. So women experience this burning or splitting pain, tearing and pressure in the vaginal area, and that happens because of fetal descent, actually pushing the baby out, pressure and distension from the vagina and the perineum. There's a pressure and pulling of the different pelvic structures and lacerations of the soft tissues. So all of that can contribute to second stage of labor pain. When you move into the third stage, things become more visceral again, right? So the third stage is delivery of the placenta. It's very similar to the first stage because the mom is starting to contract. That focus of pain from the second stage in that one area now has dissipated, and contractions are the main focus again. And there's pulling and pressure of the pelvic structures still as the placenta is delivered. Moving on into the fourth stage, pain here comes mostly from distension and stretching of the vagina and the perineum that has happened during the second stage of labor. And most of that is because of the splitting, burning, and tearing that has gone on. So the mom is swollen and edematous in the perineal area. If she's had an episiotomy or she's had a laceration that has to be repaired, the pain in the fourth stage can also be stemming from that. But also, she may be experiencing afterbirth pains in the fourth stage as well. There are a lot of different complementary and alternative therapies that we can do for individuals who are experiencing pain in the intrapartum period. We can do different types of things to help them relax, focusing in imagery, different breathing techniques. There is certain herbal and aromatherapy that can help, heat or cold compresses, Hydrotherapy or warm baths tend to help some women through the intrapartum period. Therapeutic touch and massage or effleurage can all be beneficial. Some women benefit from yoga and meditation, reflexology, hypnosis, biofeedback. Acupuncture is one that's gaining popularity as well. A TENS unit is something that you actually place on the patient, and it will send a little shock to some of the muscles. That can be helpful some. And sacral counter pressure is another thing that's helpful for back labor. And that's what you see in this photograph here. The individual has his hand in sort of right below the small of this lady's back, and he's putting some counter pressure there, and it helps relieve the pressure and pain that she's feeling in that area. We can use a whole lot of different pharmacological methods for pain management during the intrapartum period, specifically narcotics and different types of phenothiazines and adjunct meds. Demerol, Stadol seem to be one of the more popular narcotics for pain management during labor, but Nubain, fentanyl, and morphine can also be used. And then typically we always use those along with some type of adjunct medicine to potentiate the effects of the narcotic and to also decrease nausea and vomiting, so Phenergan or Vistaril. Usually we give these via some type of parenteral route, so typically through IV, but they can be given IM. They can be set up on a PCA. We use pretty small doses during the early stages of labor, and we do not use these types of meds during the late stages of labor, such as the transition phase of the first stage or the pushing stage or second stage of labor because of respiratory depression and sedation of the fetus. It's always important to have Narcan available for any type of emergencies that might occur. The advantages, though, of using narcotics and phenothiazines during labor is that it doesn't interfere with the ability of the mom's sensation to bear down during the second stage. It helps to reduce her anxiety, and it improves her ability to cope with the pain. A couple of things to think about, or one main thing to think about, is if you've given some pain medicine and the mom is telling you that she has to have a bowel movement prior to you giving her those medications, you should ask yourself, is it best for me to give these now, or do I need to perform another type of assessment? And what you would want to do is you would want to perform a sterile vaginal exam before you administered any type of narcotic medication for any patient, really, even if they haven't complained of having to have a bowel movement or complained of pressure. You always want to do that assessment prior to giving any type of medication. So an assessment of the fetal heart rate and assessment of the mom's dilation and effacement prior to giving it, because we don't want to give it too close to birth because of respiratory sedation. So what are some of the possible side effects for the mom with narcotics? Well, obviously, respiratory depression and hypoxia. It also reduces gastric emptying. So we've talked about that from a physiologic standpoint in the intrapartum period. But now, if we start adding some narcotics onto that normal physiological process of slowed peristalsis and gastric emptying, now we're really increasing the risk for aspiration and nausea and vomiting when we give narcotics. So we have to be very careful. Moms may complain of dizziness, so we don't want them up walking around. They may be more sedated. Some of them may respond with itching sensations, which can be pretty terrible if they have that type of reaction. And the phenothiazines can cause them to have a dry mouth, so they're going to be requesting water or more ice chips. Some women may become tachycardic or hypotensive in response to these medications. So making sure you're monitoring vital signs is extremely important, and having Narcan on hand for the mom and for the baby. It's very important from a fetal standpoint and a newborn standpoint to make sure you are always letting the nursery nurse know when the last dose of medication was given to the mom, because she needs to be prepared, and she needs to know how long it's been since that medication entered mom's system. Um, all of these meds do cross the placental barrier, so you may see in the fetal heart rate tracing a decrease in variability. Remember, variability is the fight and flight response that you see, that little fluctuation in the heart rate from baseline up or down. And you may see that variability decrease because when we sedate somebody, we decrease their ability to respond from a sympathetic and a parasympathetic. And that's why you see that decrease in variability. Hey, if we know why it's happening, and as long as we don't potentiate that for other reasons, or as long as it doesn't start to cause some type of fetal hypoxia or acidosis. Central nervous system depression goes along with that. Respiratory depression of the baby once it's born. Also, are sedated or they're having respiratory issues, it will impair early breastfeeding, which can be a bad thing. And it also may interrupt the bonding process. These babies also may have a little altered neurological behavior whenever they're born. So you may not see, when we talk about neurological behavior for a baby, we're talking about things like reflexes. Or you may even be looking at like jitteriness. They also, newborns also have a decreased ability to regulate their body temperature if they have some narcotics on board. So making sure that we are keeping their temperature up is important. So there are different types of anesthesias that we can offer to mom during the intrapartum period. Typically, what you see are regional anesthesias given to ladies who are in labor and delivery, but there is the ability to give local anesthesia for things like episiotomies, and general anesthesia for individuals who have to have cesarean sections. So we're going to talk about each one of these, and we're going to talk about the pudendal block first. The pudendal block is a regional anesthetic option that can be given to a mom. The thing with this one is that it's good because there are no maternal or systemic effects for the baby with a pudendal block. And basically all we're doing is numbing the pudendal nerve, which decreases or makes the sensation in the perineal area go away. We do it with lidocaine or Marcaine, so that the perineum and the vulva and the rectal areas are numbed. The thing is that the pudendal block doesn't work for really long periods of time. So it has to be timed effectively, and it is given during the second stage of labor. So the pudendal block will do nothing for contractions. It will only decrease or eliminate that local somatic pain that happens in the second stage of labor. We give it about 10 to 20 minutes prior to delivery. And the nursing care that you offer based on a pudendal block has to do with education, help coach that patient during pushing, because she may not be able to feel anything down there. So she may need your help in terms of coaching efforts, assessing the fetal heart rate and the maternal blood pressure in case of hypotension, and then making sure post-delivery that you're assessing the perineal area for hematomas or any type of infection looking issues in that area. Another type of regional anesthesia that is probably the most popular is the epidural. And this type of anesthesia inserts medication into the epidural space around L4 and L5 in the back. There's a little catheter that is slipped through those vertebrae and into the epidural space, just like a little IV catheter, so that we can continually enter medication into that space. So we can actually hook it up to a PCA and continuously infuse pain medication, or we can give a little bit here and there. So we can do it either continuously or intermittently. Typically, I've seen it done continuously. The medication we use is morphine or either fentanyl into the epidural space. It blocks the spinal nerve roots and the sympathetic nerve fibers to relieve the pain of labor, so the pain of contractions. If an epidural is placed correctly and is dosed correctly, the mom continues to have the ability to feel pressure, just not pain. So that's one reason why this is one of the most common things that's used. Indwelling catheters used to be standard for women who got an epidural. But now, with all of the research on catheter-associated infections and all of the prevention surrounding that, this really is not an evidence-based practice anymore. So some facilities that you go to, you may see them continue to put catheters in ladies with epidurals, and some facilities may have stopped. But it is not evidence-based anymore to put a catheter in. We actually offer the patient the ability we offer the patient a bedpan to be able to void every couple of hours, and a lot of them actually can still void. If we have to do an in and out cath, that is what we do typically now from a research-based standpoint instead of inserting the indwelling catheter. Again, the epidural will eliminate sensation from the umbilicus down. It usually takes effect in 15 to 20 minutes, so it's pretty quick, and it will last as long as you need it to last if you're dosing it continuously. We usually give it during active labor. We don't want to administer an epidural too early, so we don't want to give them this in the latent phase of the first stage. We want to wait until they're in active labor around 4 centimeters to give the epidural, because we don't want to slow down the labor process. Hypotension is the biggest concern with epidurals, and the reason hypotension occurs with epidurals is because there is a huge effect of vasodilation below the block. And because of that, if we dilate everything from the umbilicus down, then the body has a hard time pumping that blood back up to the heart. So it creates this pseudo hypovolemia, which will register in the body as hypotension. So when you take your blood pressure, then it's going to be very low. And it happens because of vasodilation and a decreased peripheral resistance, because we've blocked those sympathetic nerve fibers in the epidural space. So again, hypotension is your main concern with an epidural. If you have a patient who had a hypotensive episode after an epidural, we're going to administer some ephedrine to help fix that. Some individuals may be fearful that they'll end up with a spinal headache after an epidural, but the risk of a spinal headache is very, very slim with an epidural if it is placed correctly. So the only reason that anybody would get a spinal headache after an epidural is if it was misplaced into the spinal canal and not the epidural space. We always do a test dose whenever we insert an epidural into a patient, because if this medication entered the bloodstream, the mom would experience drowsiness, a metallic taste. She might have some slurred speech, some blurry vision. She could become unconscious. She could have a seizure and a cardiac arrest. So we always do a test dose once an epidural is placed. We have the mom on a continuous pulse ox. We're monitoring the baby on a fetal heart rate monitor, and we're monitoring her blood pressure. And the anesthesiologist or the CRNA will tell you that they're inserting the test dose, and he'll ask the mom, do you have any metallic taste in your mouth? Or do you feel okay? And that's what he is assessing. He's assessing to see if any of that medication has entered her blood circulation, he or she. So from a nursing care standpoint, what are we looking for? What do we have to do? What are our interventions? Before placing an epidural, you'll always have an order to give a bolus of IV fluids prior to placing the epidural. And the reason for that is because of this vasodilation that occurs in the lower extremities and below the insertion site. We want to load the mom up with as much fluid as possible to prevent that from happening. So we give the bolus up to 1,000 milliliters, but at least 500 prior to placement. We help with assisting in positioning during the procedure. The mom can either lie on her side in sort of a fetal position, or we can sit her on the side of the bed with legs dangling and help her sort of arch her lower back out like a cat. And the point of that is to open up those vertebrae in order to pass the needle and the catheter through those ligaments and through between the vertebrae. Be careful once you lay your patient back down after the epidural. We do want them to sort of be as flat as possible, not flat as in supine, but flat as in not rolled to one side or the other, because we want the epidural to work evenly on both sides. But sometimes we do have to prop them on one side or the other, and then just know that we need to flip them afterwards. We have to just be careful about that maternal supine hypotension syndrome. After an epidural is placed, we will assess the fetal heart rate and maternal vital signs continuously. We'll assess them for bladder distension and offer toileting. Do an INO. We'll monitor I's and O's, and we'll do an INO cath if we have to, if they can't void and the bladder is distended. We may have to administer some Pitocin after the epidural is placed, because it can cause contractions to slow down and cause sort of an arrest in the labor process. So sometimes we have to help them out and give them a little pit. We want to always be able to assess the ability to ambulate after the epidural is discontinued prior to getting your patient out of bed. They may be able to move their legs in bed, and they may have the perception that because they can move their legs in bed that they can stand up on those legs, and that is not always the case. So making sure that you have really assessed their ability to ambulate very good before allowing them out of bed, and always being there the first time. For hypotension episodes after an epidural, we would raise the mom's legs. We would give her oxygenation. We would give her some ephedrine, and typically all of these things are in a standing order, but giving ephedrine is what is going to fix your problem for a hypotensive episode for the mom with an epidural. Again, if it enters the bloodstream, that is an emergency. You're going to give her oxygen. You're going to give her an anticonvulsant medication such as Valium or Pentothal. possibly some Ativan, um, and there will be a prompt delivery of the fetus. If enough of this type of medication enters the bloodstream, it will cause your mom to have a cardiac arrest, and you'll be coding her. So that's why the test dose is so important. It's a cute little cartoon. I recommend an epidural at least until they're off to school. I would have to agree with that. All right, and let's talk about a spinal. So for spinal anesthesia, we're still talking about regional anesthesia, and this is just the placement of medication into the subarachnoid space, somewhere between L3 and L5. We use the same types of medications, and for the most part, we use some type of local anesthetic and then an analgesic of some kind. So it's a mixture. This particular block will eliminate sensation from the nipples downward. It has a really quick onset. In just a very few minutes, the patient will feel the effects of a spinal. The duration will depend on the type and of medications that have been mixed together and the amount. And we administer a spinal either during the late second stage of labor or prior to a C-section. Truly, I've never seen a spinal given for a vaginal delivery. It's mostly used for C-sections because people these days tend to get the epidural. The effects of the spinal are pretty much the same as they are for an epidural. So hypotension, again, is your main concern. Fetal bradycardia can occur, loss of bearing down, so the patient won't be able to feel the ability to push if they're getting it for a vaginal delivery. And this one has the potential to give the mom a spinal headache. They sometimes will get a lot of itching, and that's typically due to the morphine or the fentanyl analgesic that is mixed up with the local anesthetic. And bladder, uterine, and atony can also be a side effect of the spinal. So we have to watch these people very closely for bladder distension, and we have to watch them closely for bleeding issues after delivery. Or if they are having contractions, we might have to give them some Pitocin if they're having some uterine atony. Advantages are that it allows the mom to stay awake during the C-section. You can think of the spinal as a one-time shot. So here's a photograph of the difference between a spinal and an epidural. So this little blue catheter is an epidural, and you can see how tiny that space is, the little purple space. That's the epidural space, and it's inserted, and we leave it in there. And we can insert medicine in here continuously or intermittently. The spinal, on the other hand, is what you see here with the needle, and this one goes all the way through the epidural space into the spinal fluid and the spinal canal. And we enter medication in there just one time. So again, a one-time shot. Here's another photograph of that. I don't know how it got off to the side here. But all these little nerve endings coming down from the spinal column. This gray piece up here is your spinal column, and all these gray things hanging off is the cauda equina. Those are all the little nerve endings coming off your spinal column. An epidural is on the outside of this, all the way on the outside of this blue area. That's the epidural space. So that's where your epidural would go. The spinal, however, would go all the way in here. We want the spinal block to block up the nerves that are inside this blue area. This is a picture of the effectiveness of some of pain relief measures during labor. This came right out of your ATI book, so you guys can look at that in there, but it just talks about the timing of pain relief and how long it will last. General anesthesia is something that we only use in the event of some type of complication related to an emergency, whenever we cannot, for whatever reason, do a nerve block. So potentially that might be a patient who's had back surgery in the past, and they can't have if they've got plates and pins and screws, and there's no way that they can get in a position to allow the placement of a spinal or an epidural, then those individuals might have to just go to sleep. Or we can do this in an emergency situation when there is not enough time to place a spinal. General anesthesia is done using pentothal and succinylcholine. Pentothal is a rapid induction medication. It has a really short half-life, so this puts people to sleep. And the good thing about it having the short half-life is because it allows for achievement of good uterine tone after delivery or quickly. So if it wears off quickly, then it won't cause uterine atony for sustained long periods of time, which will decrease the risk for hemorrhage after delivery. Succinylcholine is a relaxant, so it actually will relax the airway and allow passage of the endotracheal tube and allow ventilation to be easier. So again, what we do is we produce unconsciousness in the person due to these medications, and then we actually will intubate them. From a nursing standpoint, it's important for you to keep the mom in PO so that there's no risk of aspiration when we put down the endotracheal tube. You have to monitor the fetal heart rate and the maternal vital signs. General anesthesia will cross the placenta, so it will cause effects for the fetus as well. So once a mom is placed under general anesthesia, the goal is to get the baby out as fast as possible, so there are very little effects from the general anesthesia on the fetus. You want to make sure you have good IV access and that things are infusing well. These patients will get a histamine H2 receptor blocker, something like Rantadine or Zantac prior. Pepsid is another one. They'll get that prior to general anesthesia. They will get some Reglan to help increase gastric emptying. Positioning of mom during a C-section or general anesthesia is very important because we don't want her to suffer from any type of maternal supine hypotension syndrome. So putting a wedge under her right hip so that we can get her turned towards the left side and prevent that. Cricoid pressure is something that has to be done whenever you're intubating somebody, and cricoid pressure is applied by somebody who's trained to do so on the little cricoid bone here in the neck, and it allows visualization. It allows the CRNA or the anesthesiologist to be able to visualize the vocal cords so that they can slip that ET tube through those more easily. Always assess these people for uterine atony postpartum. So, because if we're giving them a paralytic agent to induce anesthesia, then we're not just paralyzing their ability to move or paralyzing their airway, we are paralyzing everything. So we want to make sure that we're assessing the uterus and doing good fundal rubs, making sure that it is nice and firm, and if it's not, massaging, because we don't want any type of postpartum hemorrhage. And for these individuals, facilitating bonding as soon as possible with the newborn, because they're going to be very groggy, and also noting safety matters as well. If your mother is very groggy from the anesthesia, but she still is a little awake, we would never go in and allow her to hold the baby in the bed and walk out of the room. We would always be there by her side. So always thinking of safety issues from a maternal and a fetal standpoint. So here's some nursing diagnoses related to labor pain. The goal of pain management during the intrapartum period is that we can maintain their pain at a tolerable level throughout labor and delivery. It is not to get rid of all of the pain. That cannot be a goal during labor and delivery because it is not possible unless you are asleep. And then you have pain when you wake up. So the goal is to make sure that we maintain that at a tolerable level to the patient. And educating them and teaching them about that up front is so important because they should never go into labor or delivery expecting that they will have no pain or that you as the nurse will be able to take it all away. So making sure their mindset is in the right spot from an educational standpoint is very important. Again, the goal of pain management has to be focused towards the safety for the mom and for the baby because we're talking about two patients. Effective relief is the goal, not total relief because that's unrealistic. We want to use the minimum amount of pain management possible, the lowest effective dose, again, because we're thinking about the safety of the mother and the fetus. And we also want to use whatever is going to give us the least side effects. We want the patient to have maximum active participation. We want them to listen. We want them to respond. We want them to communicate with us. And as the nurse, you have to be doing the same thing. And in the end, we're hoping that this is a pleasant experience for her and for her family. Your responsibility is to make sure that you've timed meds appropriately, that you're not giving things too early or too late as the nurse. You want to make sure you've done your assessment, that you've done your vital signs before, during, and after any type of pain management, that you have a good understanding of what her allergies are and any allergic reactions that could occur and that you're prepared for those. You want to give them education related to the drugs that they're receiving. If they're getting an epidural or a spinal, are the consents signed and are they done prior to? And then considering too the gestation of the fetus and the condition of the fetus. If the baby is not looking good, if there's something about the fetal heart rate tracing that worries you, that you don't feel good about, then we wouldn't want to give mom a narcotic that could potentiate the any type of hypoxic event that the fetus might be experiencing already. So making sure that you're assessing both patients before giving any type of medication. And then obviously evaluating the effectiveness of those. Pain is what the patient says it is, and we have to always remember that. So make sure that you also are thinking about things from a religious standpoint. What are the patient's beliefs surrounding labor and labor pain? Sometimes their ethnicity and their race plays a role in how they experience pain and how they respond to it. And then also take assessment of the birth environment. Who's there for her support during labor and how are they responding in terms of your management of her pain? So questions: the nurse is caring for a client in active labor and she reports lower back pain. The nurse suspects that this pain is related to persistent occiput posterior fetal position. Which of the following non-pharmacologic nursing interventions is appropriate? So we're looking for non-pharmacologic nursing interventions related to lower back pain. And the correct answer for this one is B, sacral counterpressure. because that is used, it's a non-pharmacologic method that is used to relieve pressure in the lower back region. Question 2, the nurse is in the labor and delivery unit and is caring for a client in the second stage of labor. So that's the pushing stage. The client's labor has been progressing and she is expected to deliver vaginally in 20 minutes. The provider is preparing to administer lidocaine and perform an episiotomy. Which type of regional anesthesia block would the nurse anticipate the provider to administer? Okay, so we're in the second stage of labor, so the mom is pushing. She should be delivering in around 20 minutes time, and we got to perform an episiotomy. So if we want to utilize some type of anesthesia method, and we are getting ready to do an episiotomy, we obviously want to be numbing up the perineum. So the answer for this is A, the pudendal block. We also know that this is only going to last for about 20 minutes. And our last question, the most important nursing intervention for a client in labor who has just received an epidural anesthesia would be to monitor the B, mother for hypotension. This is the most common complication and adverse reaction to epidural anesthesia and spinal anesthesia, actually. So that's what is our priority. Okay, I think I'm going to cut things off here because I've been talking for a while. So I will finish up with individual module 5.2, PowerPoint 2, and lecture 3 on the next go around. Thanks for listening.